The papers in this video are in the April issue of the Journal of Vascular Surgery and are great examples of the quality of the papers published each month. The first is The Editor's Choice by Deary and colleagues from Boston. Since there is debate about the impact of gender on the outcome of repair of abdominal aortic aneurysms, the authors used a NSQIP database to evaluate sex differences in intact AAA repair. They used the NSQIP program to identify patients undergoing endovascular aneurysm repair, that is EVAR, or open repair for intact infrarenal abdominal aortic aneurysms from 2011 to 2014. They identified 6,660 patients, with 19% being women, who underwent intact AAA repair. 87% of the procedures were EVAR. The women were older, had slightly smaller aneurysms, and more chronic obstructive pulmonary disease. Among the patients undergoing EVAR, women had slightly longer operative times, but after open repair, women had slightly shorter operative times. The 30-day mortality was higher in women after EVAR at 3.2% versus a mortality of 1.2% for men, and also after open repair, where the mortality was 8% for women and 4% for men. After adjusting for repair type, age, aneurysm diameter, and comorbidities, female sex was independently associated with a mortality odds ratio of 1.7 and major complications odds ratio of 1.4. However, after adjusting for the aortic size index, which is a measure of the size of the aorta compared with body size, rather than for absolute aortic diameter, the association between female sex and mortality and major complications was reduced. The authors concluded that women were at higher risk for 30-day death and major complication after intact aneurysm repair, but some of this disparity may be explained by differences in the aortic size index. The CME paper of the month is by Hicks and colleagues from Johns Hopkins and the University of Colorado, and is entitled "Operative Variables Are Better Predictors of Post-Discharge Infections and Unplanned Readmissions Than Patient Characteristics." They analyzed the reasons for vascular surgery readmissions in the 2012 to 2013 American College of Surgery NSQIP data set of vascular surgery patients for post-discharge infections and unplanned 30-day readmissions. They identified 86,000 patients who had a 30-day readmission rate of 10%, and 90% of those were unplanned. The unplanned readmissions were related to the index vascular surgery procedure in 61%, and infectious complications were the most common reason for readmission, with surgical site infection being the most common reason for unplanned readmission. The top 5 preoperative risk factors for post-discharge infections were the presence of an open wound, inpatient procedure and operation, obesity, and insulin-independent diabetes. When operative and post-operative factors were included in the model, total operative time was the strongest predictor of post-discharge infectious complications, with an odds ratio of 1.2 for each 1-hour increase in operative time, and that was followed in risk of complications and odds ratio by the presence of a preoperative open wound, obesity, and discharge to rehabilitation facility. Surprisingly, insulin-dependent diabetes, cigarette smoking, dialysis-dependent, and female gender were, although also predictive, had smaller effects. The authors concluded that infectious complications dominate the reasons for unplanned 30-day readmissions in vascular surgery patients, and that preoperative, operative, and postoperative risk factors were more important than the expected risk factors such as diabetes, obesity, renal insufficiency, and cigarette smoking in predicting infectious complications. Their findings suggest that careful operative planning and expeditious operations may be the most effective approach to reducing infections and readmissions in vascular surgery patients. The next paper, Endovascular Management of Chronic Symptomatic Aortic Dissection with the Streamliner Multi-Layer Flow Modulator by Sultan and collaborators, reported on the 12-month outcomes of patients with chronic symptomatic aortic dissection managed by this new device. Of 876 implants, 12% were identified as having been placed due to an aortic dissection, including Stanford A and B type dissections and one mycotic Stanford B dissection. There were no reported aortic ruptures or aortic-related deaths, and the 12-month freedom from neurologic events, end organ ischemia, renal insufficiency, and paraplegia was 100%. Dissection remodeling occurred with a significant reduction in false lumen diameter at 12 months. Although long-term studies will need to confirm this initial report, the authors conclude that this device is an option in complex pan-aortic dissection, and it leads to aneurysm stabilization. The final paper, Carotid endarterectomy should not be based on consensus statement duplex velocity criteria, by Colombo and co-authors from Dartmouth and the University of Utah, examined the widely used criteria of a internal carotid artery peak systolic velocity of 230 as the measure of a greater than 70% stenosis. They reviewed the outcome of patients with a greater than 230 centimeters per second stenosis who were managed medically for outcomes of TIA and stroke. Asymptomatic patients were included if their internal carotid artery peak systolic velocity was greater than 230 centimeters per second, but less than 430 centimeters per second, which is the criteria for a greater than 80% stenosis. 327 patients with a mean follow-up of 4.3 years and with 85% followed for greater than 3 years had only 4 unheralded strokes at 1, 17, 25, and 30 months that were attributable to the index carotid artery, and the ipsilateral TIA occurred in 17 patients. Revascularization was performed in 59 patients, 1 for stroke, 12 for TIA, and 47 of progression of asymptomatic disease to greater than 80%. Freedom from carotid etiology stroke was 99.7%, 98%, and 98% at 1, 3, and 5 years respectively. The authors conclude that patients with intermediate asymptomatic carotid stenosis do well with medical therapy when monitored and intervened upon using conservative carotid duplex ultrasound criteria, and that a substantial number of patients undergo unnecessary carotid endarterectomy if consensus statement thresholds are used to recommend surgery. Thank you for your attention to this video, and I hope you enjoy the April issue of the Journal of Vascular Surgery.